Hello everybody and welcome. My name is Ray. I am the lead for the MNVP, which is the Maternity and Neonatal Voices Partnership in Northumbria. And I'm here today with two Katies. Just to confuse you a little bit, I have got Katie Barker here, who is consultant obstetrician.
Yep.
And then I've got Katie Lisserman, who is our head of midwifery. And today we're going to talk a little bit about personalised care at Northumbria and exactly what that means for people and what that means for you if you're having your baby here. So I'll start off with what might be an obvious question, and I'll ask Katie, what is personalised care and what does that actually mean in Northumbria if you're having a baby here?
Thanks, Ray. So personalised maternity care means as a team of health professionals supporting women and birthing people during the pregnancy care. It's around listening to the needs and us as providers of that care responding. So it may be that it's around supporting choice, as there are different options during the pregnancy pathway. There are lots of opportunities to respond and offer personalised care. It may be around the place of birth, or there are lots of opportunities. It's around listening, it's around understanding, and it's around discussing together, the woman and the people providing the care, understanding how that care can be tailored and quite individual and responsive to the needs of the woman.
So really, it's about thinking, if I'm pregnant, it's what I want, and it's how I want to be looked after, and it's how I want to give birth.
That's right, Ray. So it's around us understanding and then sharing options so that the woman can make choices that are personalised to her.
Because I guess that's it, isn't it? That everybody's ideal birth is going to look very different, and different people want different things.
Absolutely, and we want to be able to offer choice so that women feel in control of the care that they receive during their pregnancy.
And I guess that might change as well. You know, things.
Of course.
When you start off and you first find out you're pregnant, it's not. You're not always in the same place when you actually get to give birth either. Anyway, are you?
You're right, Ray. So we need to respond to the changing clinical situation during pregnancy and beyond, because personalisation doesn't end when the baby's born. You'll continue to be offered choices around your care in the postnatal period and beyond.
Brilliant. So some of the questions when I go out and speak to mums and dads and parents who are using services, they often have questions about personalised care and where to have their baby and how they're being looked after. And some of the questions they have do include, for example, why are home birth numbers always quite low? Or they seem quite low in comparison to the numbers of people who give birth?
So you're right, like the number of births, the number of babies born at home is a very small proportion of the total number of babies born at Northumbria. But again, that's around women choosing to come and give birth in hospital, and that may be at the hospital in Cramlington or one of our midwife-led units in Hexham, Alnwick or Berwick. So obviously the number of births reflect where women have chosen to give birth. But there may be reasons why women are choosing to give birth in hospital. So it is around us understanding during the pregnancy if there have been any pregnancy complications, and it may be that we've recommended hospital birth and women have, you know, continued with our recommendation and are giving birth in hospital to support their recommended care.
Okay, and our sort of home birth figures here in Northumbria, would you say they're sort of in line with like the rest of the region or the rest of the country?
So here at Northumbria, really over the last 5 years, we've had a typical home birth rate of about 25 per year. So you may think that's quite low, but actually we also, like I've mentioned, have the births in the midwifery-led unit hospitals in Alnwick, Hexham and Berwick. And so we have a proportion of babies that are being born at home, but we also have babies being born in other low-risk birth settings in our midwifery-led units. But the they compare comparatively. There isn't anything exceptional about Northumbria, and it's just making sure that if women are requesting home birth, we're understanding and working with women to assess suitability to give birth at home.
So yeah, and that makes sense, because what you're saying is that every parent to be, every mum to be, should be able to have that discussion with their own midwife and with their obstetrician, if they have an obstetrician as well, to actually work out from a personalised point of view where the best place for them to give birth is, which might be at home, but might be somewhere else.
Of course, yeah.
Perfect. And then one of the other questions that I do get asked a lot as well is sort of similar, is that water birth numbers seem quite low if you look at the total numbers of births each month or each year, and the number of water births seems quite low. So is that for a similar reason, or are there other things going on there?
I think we just need to remember when we're thinking about that personalisation, it's around, you know, the water birth numbers reflect the women that have chosen to use water during labour and for birth. So some women will choose to use water during labour, but then may get out of the water for birth. And we have acknowledged that the number of women using water is quite low, and we did do a training day with our midwives and students and obstetricians very recently to really encourage and offer the use of water for women in our hospital and home birth environments, to really encourage them to consider the use of water. But let's just remember that not everybody may want to use water, but we very much encourage the use of water as an option during labour and birth.
So it's almost presented as part of the, you know, that there's lots of different pain relief options that you could use, and that would be one of them.
And I think we should discuss that actually, that again, it's around recommended care. So Katie, might be worth us discussing that actually there are some situations where we wouldn't recommend the use of water, and that may be reflecting in the statistics.
So there's some ladies who we speak to who we might feel are suitable for having the labour in the water, but actually more sensible to get out for the birth, because the birth might be more difficult. So, for example, someone that's got a bigger baby on board. But there's some women that we wouldn't usually recommend go in the water at all. So someone that's got preeclampsia or epilepsy, who's at risk of having a seizure, or for some women who have a slightly bigger BMI, if their weight is over 100, from a patient and staff safety point of view for emergency
so it's 100 kilograms,
100 kilograms,
is it? Yeah.
Sorry, yes. We wouldn't usually, we wouldn't allow them to go in the pool because of for evacuation purposes from the safety of mum and the staff involved. That's kind of one of our kind of criteria to not go in the water.
That makes sense. Yeah. And how many pools do you have at NSEC?
Yep, so we have 2 pools on the birthing centre at NSEC. We have a pool in each of our midwifery-led units, Hexamanic and Berwick, and then some women choose to hire a pool and use a pool in the home birth environment.
Yeah, that makes sense. And how common is it that both pools are in use at the same time, and someone might come, because I know that, again, that is something that women speak to me about, and they're a bit worried, oh, I really want a water birth, but what if they're too busy? It might put you on the spot a bit, but how common might that be?
I think because we've got the 2 pool rooms, it's a very busy birth centre. We deliver lots of babies at Northumbria. The birth centre is typically a very full department, but it's around understanding if a woman's choosing and requesting use of water, even if that room's occupied, sometimes we can make arrangements if there's somebody in the room that's already used the pool or had the baby. It's just around coordinating the care and trying to release that room to enable the use of water. So I would say in reality, it's unusual to request water and not be able to use the pool because the room is being occupied without an arrangement that we can hopefully come to.
Yeah, that sounds really good, and actually brings us really nicely back, because what you're saying is you personalise the care.
That's right.
That's absolutely perfect, so thank you. So obviously that's sort of one end of the birthing spectrum, but there will be, as we were saying, it's about personalised care, and we know that some women would rather choose a caesarean section, for example. So what choices do women have if they're considering a caesarean section? And I know there's sort of different types, and you know it happens under different circumstances.
And personalised care is something that we really try and work towards. And I'd say 10 years ago, we were almost encouraging everyone to aim for a vaginal birth, and people had to go through quite rigorous psychological assessments. So I'd see the mental health team if they were wanting to have a caesarean section without any medical indication. But now it's very clearly written in national guidance that if someone wishes to have a caesarean section as their opted mode of birth, that we would support them with that decision. And as long as we've had a good discussion about the risks of post-caesarean section and the alternatives, whether that would be a planned induction of labour or again, awaiting natural labour, it's something that we support really openly with our department, and that probably reflects on why our caesarean section rate is increased slightly over the years, and that is in line with women's choice regarding that.
And how does the sort of caesarean section rate in Northumbria sort of compare with sort of comparable hospitals or trusts?
I'd say our emergency versus elective caesarean rate is pretty equal, so about 20% for each, so 40% overall. But there are some places in the UK where it's approaching 50% now, and so us to have a 40% in caesarean section rate is in keeping with the rest of the region, but also nationally as well.
Okay, and what sorts of, as a non-medic, so what are the sorts of reasons that someone might need an emergency or an unplanned caesarean section?
So the biggest reason for an emergency caesarean section, it can be something as simple as the birthing person has gone into labour before their caesarean section date. So we wouldn't routinely organise a caesarean section before 39 weeks unless there was a medical reason for it, because we know after 39 weeks the babies are much less likely to have breathing, feeding, temperature control issues, and less chance of going to special care. Whereas before 39 weeks, that chance is significantly higher. So we tend to plan caesareans after 39 weeks, but about 15% of people probably actually go into labour before their caesarean section date. We don't say, sorry, you've not made it to your date, you're not going to have a caesarean, even if there was no medical indication for it, and we would support that as an emergency.
So that's
caesarean.
interesting. So you're saying, and I hadn't even considered that there might be someone who had planned to have a caesarean section, but then they go into labour.
Or the waters break.
Or their waters break earlier. And rather than sort of saying, tough, you've missed your chance, you actually would still say, right, we'll rearrange things and we'll get you in now, because...
So quite a large percentage of our emergency caesareans are actually for ladies who were planned for elective ones but have come in labour.
It's almost like they got there first. But essentially,
so that technically fits one of the criteria for an emergency caesarean, although it's not an emergency as such.
Because I think that's it, isn't it? When you hear emergency caesarean, I always think it's almost like, you know, there'll be an ambulance, you'll be rushed down the corridor, bouncing off the walls, and quite a lot of the time it's not necessarily like that.
And there are other medical reasons why we need to do emergency caesarean sections. So because we do have like quite significant concerns about either mum or baby, or labour's not progressing. So it might be that you've got stuck at 4 centimetres. It might be that your baby's starting to get stressed with the labour. It might be because there's been some bleeding, or you have a medical condition which has actually worsened. So, for example, you've got preeclampsia and you're only 32 weeks, but actually we can't treat the preeclampsia anymore, and the only option at that stage is to deliver the baby. So there's different categories of emergency caesarean section. There's some where we want the baby to be delivered immediately, and there's others where it's classed as an emergency, but actually we've got 24 hours to deliver that baby, and we do it at the next safest opportunity.
And I guess that sort of brings it in nicely as well, because that means there is time to have those discussions with like mum and dad and family and a doula, if there's a doula there, so that there's a real understanding of, again, like risks and benefits and why, because I can imagine it's quite a shock if you've got in your head that you want to have one type of birth, and then something changes, and you have to change what's happening. So that time matters, doesn't it? That discussion.
Yeah, and the majority of time, we absolutely have time to do that and have those discussions, and make sure people are fully informed with why we're recommending what we are.
That's really helpful. So if that's emergency caesareans, and I know we've talked a little bit about planned caesareans, so what might be some of the reasons that there would be a pre-planned caesarean?
So there's a lot of ladies now that just opt to have a caesarean section because they feel that gives them more control. So whether that's more control with knowing which date their baby is going to be arriving on, whether that's they don't like the thought of having an unexpected emergency caesarean section, they suffer from anxiety, or it's just what they've always wanted to have. Obviously with a caesarean section, you avoid the risk of having any trauma as well for from the birth canal, and people just sometimes feel that is the right decision for them. Other people might have had a caesarean section before, 1, 2, 3, 4 caesareans before, and actually it's their preference to have a repeat caesarean, or it's something that we recommend once they have had a couple before. Or it might be a medical condition which is causing it. So it might be they've got something which stops them having a vaginal birth. It might be that they're early in the pregnancy and we need to deliver at a stage where we can't really induce. Or it may be that the baby's just not deciding to go head down and flying across the way or breech. It's mum's choice to, instead of us trying to turn the baby, mum just opts to have a cesarean section.
That's all really interesting, and it really does again bring home to me there's the choices there, but there's also the fact that you've given me loads of different reasons, and it just goes to show how many individual situations there are, and that actually it's not as simple as saying you're in position X, you have to do.
And there's probably 100 other things that I can tell you as reasons.
And that's it. And it again brings home how important it is to have those discussions with your midwife and your doctor and come up with a plan of action that is really.
Ray, I think there's an important message here as well, because there doesn't need to be an indication or a reason to have a planned caesarean section. This is around personalised care. We're supporting choice. You don't need to have a reason. You can choose to deliver your baby by...
is as important. Yeah, absolutely. And I guess this is it, isn't it? That we know that some people, their choice would always be to have a baby at home. Others would always choose to have a baby in hospital, and others would say, actually, I want a caesarean, and that's enough.
And as a maternity service, we're here to support that choice.
Yeah,
we have some ladies who have absolutely no obvious reason other than it's their preference to have a caesarean section, and they absolutely would not want a vaginal birth under any circumstance. At the other end, we have some people that have significant risk factors for having a vaginal birth, and yet
feel really strongly
they want to do absolutely everything to try and achieve that. So it's just important that we discuss the risks and benefits of each situation and what it would look like for them.
Which is, that's informed choice, isn't it? And informed decision making. And I guess it's tricky, isn't it? Because sometimes it doesn't feel like a choice. And that probably, I imagine, for mums can be really hard, that they know that the medical suggestion, for very good reason, is to do something that they wouldn't necessarily choose. And that's the importance of having a really strong team around you, isn't it?
You know, there's some situations where we absolutely, it would be impossible to have a vaginal birth and end up with a healthy baby.
Yeah.
And unfortunately, that is a true case in some situations. But majority of times, we can have that balanced discussion about options.
Yeah.
And we try to support women who are in our care to see the same health professionals during their pregnancy, because you're building a relationship together, you're understanding the preferences around care, and hopefully building on conversations that support choice and together reaching agreement around what the plan of care is going to look like for the woman.
That makes sense, because if someone understands you and your values, and you've got that mutually sort of trusting relationship, that puts you at an advantage immediately, doesn't it? So that's really helpful. Thank you. I know one of the other things people often ask me about is induction of labour, and it's really interesting because sometimes I speak to mums who are sort of 38, 39 weeks pregnant and they're fed up and tired and a little bit achy, as we've all been, and are almost desperate to have their baby. And then you get other people who really don't want to be induced because they've possibly, heard stories or whatever. But it would be really interesting about some of the, as you'd say, some of the reasons for induction of labour.
Yeah. So again, it comes down to a lot of shared decision making about like the recommendation for induction of labour and the timing for the induction of labour as well. And some women would just opt to have a induction of labour or have that preference because they want more of a controlled delivery. They know when baby's going to arrive. They know that they can organise their childcare. They know that if they've had a previous really quick delivery before, they're worried about delivering at home. They want something a bit more controlled in hospital. And the same with the caesarean section. We wouldn't normally offer that before 39 weeks unless there was a medical reason for it. But it's something that we could discuss around about the due date, if that was something that the women wanted. But there are also an awful lot of other reasons with medical kind of reasoning behind it why we might offer an induction of labour in that situation. So there's certain medical conditions like diabetes, preeclampsia, people that have got a smaller baby on board, people that have got a bigger baby on board, and some people think, well, I don't want an induction under any circumstances. Some people think, well, I want my baby out as soon as possible, and it's really hard to anticipate how people are going to respond to your discussion, and it's having that that kind of shared decision. Do you want to? I guess this is the risks if we induce you now. To you, this is the risks to baby if we induce you now. This is the risks if we let things go a bit longer, and this is so it's just going to balance.
Yeah, and that sounds like a really nuanced, personalised discussion, and I guess everyone assesses risk differently. So what to me might be an acceptable risk, to you you'd be like, no way, I'm not.
And I think what we need to remember is that we're having supportive conversations around induction of labour to maintain wellness of mum and baby during pregnancy, and trying to deliver baby at a time that feels right when considering some of the maybe complications of pregnancy that Katie's described. Or it may quite simply be that the pregnancy's progressed beyond the due date, and actually the baby's mature and post expected due date, and we do offer induction to at term plus 7 days of pregnancy, so that's 41 weeks.
Yeah.
We offer induction at 41 weeks, and again that's around trying to ensure that baby's born at a gestation that typically supports wellness, and we don't have any post-mature complications in the pregnancy.
Yeah. And that's not the right decision for everyone, and when you get to 41 weeks, if you did want to continue the pregnancy to 42, we didn't have any of the other kind of risk factors that made us worry. And there's not any increased risk of continuing the pregnancy to 42 weeks if that's your preference. Once you go past 42 weeks, the risks do increase slightly. So there is, although very, very small, there is a double the risk of stillbirth at that stage, but still it's only 3 to 4 births per 1,000.
What's that in a percentage?
0.3 to 0.3 to 0.4.
So you're talking.
So it's still very, very small. So it goes from 0.1 to 0.2 up to 0.3 to 0.4. So still very, very small risks. And we do, if you didn't opt to have an induction when we have offered it, whether that's at the 42-week mark, whether that's earlier on in the pregnancy and you've got a medical complication, we would have that discussion about, do we offer extra monitoring at that stage? So
again, it's very personal. Yeah. It's based on the whole picture as well, not just here's the calendar.
It's
but
together.
What else? Yeah,
reach an agreement together around
and feeling supported.
A plan of care that supports mum to continue to be well in her pregnancy, and also baby.
That's brilliant. And just also on induction, I know this is the kind of thing that people ask a lot as well. So if you're induced, does that increase the likelihood of having like a longer labour or a more painful labour, or are you more likely to end up having a caesarean or a forceps delivery, for example? Because I think that might be, I know that might be why some people then say, well, I don't want to be induced, I'd rather have a caesarean, because it's, but again, balancing it.
There are older studies which suggested that it did actually increase your risk of having a caesarean section, but the newer evidence, the newer studies suggest that actually having an induction of labour doesn't increase your risk of a caesarean section, especially for second-time mums.
Okay.
But even for first-time mums, there's the evidence is suggesting that actually it doesn't increase your chance of a caesarean section. And there's some studies that actually say a slightly earlier induction of labour. So instead of waiting to 42 weeks, having a little bit earlier, it can reduce your chance of having a caesarean section, because if you think about it, I guess the baby's slightly smaller. When it comes through the birth canal. It is a longer process. So when you go into labour naturally, your cervix has naturally made some changes, your hormones are already naturally being produced, and an average first-time labour for a mum with a first baby is about 8 hours, 5 hours with a second baby, but the induction process does take longer, so it sometimes can be 18, 24 hours before we get to the stage where we break your waters, and then the process of starting the contractions after that. But it's so variable from person to person, and some people have a very short induction. Their baby is here within a few hours of them arriving. There are some people where it may take a bit longer as well. But it's really hard to predict who's going to be in which situation.
And I guess that's part of the conversation you have when you're discussing an induction of labour, isn't it? Because again, everyone's different. So
And it's being prepared for that because
well, that's
actually we are stimulating a physiological process, but we're artificially stimulating it through medications. So it's just accepting that it's slightly different, and you'll be in hospital during that induction phase before you're in established labour, where if you've chosen a hospital birth, you would expect to be in hospital during those more kind of later stages of the labour.
That makes sense, because, I guess if you've gone into labour naturally, you'd stay at home initially, whereas what you're saying is you'd be in hospital
starting
for
the
that
process at the hospital, and it's about being prepared for that around a longer stay and how that impacts on you and the rest of your family, and preparing from everything.
Knowledge is power, isn't it? It's making an informed decision. You need all that information, don't you? So,
and I guess the next 2 points of your question almost like come into each other. So about the forceps or the instrumental delivery, and the pain with an induction of labour as well. So it's very hard to say, is it more painful, because there's different factors that kind of feed into that. So when we induce you, we're artificially breaking the waters and giving a hormone drip, and quite often the contractions will come on faster than they would have done, so your body's not used to it. So when you get that gradual build up, you're almost like preparing as the contractions build up, whereas when we're starting them off or breaking your waters, they tend to come a little bit thicker and faster. Sometimes they're a little bit closer together because we're trying to really optimize and getting the contractions coming as well as we can, and because it is a longer process, you don't sleep as well in hospital as you would in your own house, and probably psychologically it's different to going into labour naturally, so that you are more likely to have a bit more pain relief, so more likely to have an epidural, which isn't a bad thing at all. They're wonderful things.
Well, some people, I speak to people, and some people are really scared that they won't get their epidural in time, and other people are like, I just don't want an epidural, and I don't want anyone to suggest it, and then everyone in between. And I guess that brings us nicely back to the fact that everyone's different, and it's very much about a personal, supported, personalised choice.
Everybody's experience is different, and we are here to respond to that experience of labour or induction, and make sure that we can, just support the needs of the woman during the induction or labour process.
So when you have an epidural on board, we do know that you are slightly higher chance of having instrumental delivery, so a forceps or a Von 2s, and that's just because you don't have the same sensation as when the epidural's not in place. And sometimes if you've been pushing for a while, if you're getting tired, if your baby's getting tired, and we do offer assistance with the birth. And that isn't uncommon for a first baby, whether that's a spontaneous labour or whether that's an induction, to be honest.
And can I just ask as well, obviously you work really closely with whatever the guidance are. So the guidelines that you have here at Northumbria, are they in line with national guidance, or do you like tweak them?
Absolutely in line with
Yeah.
national guidelines.
Which is all research, you know, that's very
Evidence-based.
heavily
Yeah.
evidence-based, yeah. Okay, so we've been talking a long time, so we will try and like wind it up a little bit. But it'd be really interesting to hear from both of you, what if you could give an example of what you think the ideal sort of version of personalised care at Northumbria might look like, you know, if you take your imaginary woman and what that might look like with supporting her and her family.
I mean, I want every woman or birthing person in our care to feel listened to and feel like we've discussed options so that there is choice and the woman feels involved, informed to make choices around recommended care.
Lovely.
I don't think I can give a better answer than that.
Oh, there you go. Perfect.
But just,
Okay.
yeah, just having the time to listen to what the choice is, have a discussion about what their preferences are, what their risks are, what the recommendations are based on that discussion. And I think the most important thing is saying that no one person's care looks the same.
Yeah.
You might have two people with exactly the same medical problems or size of baby, and your discussion with both people is going to be completely
Yeah.
different because they've got their own personal preferences. So it's just
Yeah.
making sure that we can try.
I like that. So that's it, that on paper you've got two identical people, but actually their preferences might be completely different. And that as professionals, your job is to meet them where they are and make sure that they get what they need.
Yeah, and it's just for us making sure you've got the right information
Yeah.
to make that decision.
It's brilliant. Thank you very much.
Thank you, Ray.